So today we're going to discuss about the Mrcp basis consultation station, and I'm going to talk a bit about rheumatoid arthritis today. This is a very important case, and there is a high chance that you may come across this case in your consultation station. So let's start our case. So first of all, I like to talk a bit about the history. So this is a 38-year-old woman who is presented with 2-month history of worsening painful joints in her hands and feet. The pain is worse in the morning and is associated with marked stiffness and difficulty using her hands. In addition to this, she has recently lost about 3 kg of the weight unintentionally. She denies any respiratory, cardiac, ocular, or skin symptoms. She had no preceding illness and is usually well. However, she is a current smoker. Her sister was diagnosed with rheumatoid arthritis about 1 year ago. She lives at home with her husband. So remember that rheumatoid arthritis, it is around 2 to 3 times more frequent in women compared to men, and it commonly presents between the age of 30 and 50. However, it can occur at any age. Usually, rheumatoid arthritis, it has a subacute onset. Inflammatory arthritis, arthritis symptoms lasting more than 6 weeks. These are suggestive, and actually it forms one component of a current classification criteria. In addition to the additional point in the criteria include patterns of joint involvement, serology, and acute phase reactants. So whenever we have a joint pain, a clinical approach to the joint pain should include eliciting the time course. So we like to know whether it is acute, subacute, or chronic. Pattern of joint involvement, like the distribution, symmetry, and number of joints, that is whether it is mono, oligo, or polyarthritis. And on the history, you should try to distinguish between the mechanical versus inflammatory pain. So when the patient has a symmetrical small joint polyarthritis, it is a classical presentation of rheumatoid arthritis. Less typical presentations, they include sudden onset widespread arthritis. Sometimes patient can have a large joint mono or oligoarthritis, or polymyalgic symptoms, or a systemic illness with prominent constitutional symptoms as well. So distinguishing mechanical from inflammatory pain is a core skill of the rheumatological assessment. Diurnal variation in symptoms with pain that is worse in the morning or after periods of rest and better later in the day or with movement is classic. Joint stiffness actually is a key feature on history suggesting an inflammatory basis. Specifically, the duration of the early morning stiffness is informative, with morning stiffness lasting more than 1 hour, highly suggestive of inflammatory arthritis. And while we are taking the history, it is very important to establish functional impact of symptoms as part of an overall assessment in patient with joint disease. Functions may be impaired by active joint inflammation, but may be as a consequence of secondary irreversible joint damage. So one should ask question about mobility, including the use of any gait aids, ability to perform personal care and household tasks, and impact of symptoms on work, relationship, and hobbies. Briefly about the constitution symptoms, like unintentional weight loss, these are common in poorly controlled rheumatoid arthritis, and normally these are mediated by cytokines such as TNF. So if the patient has a weight loss, it should prompt a close review of disease activity as well as consideration of other differential diagnoses, including infections, as it is the infection risk is high because of the immunosuppression, malignancy, there's increased risk with rheumatoid arthritis, and also think about thyroid dysfunctions because due to the predisposition towards comorbid autoimmunity. So this patient denies any respiratory, cardiac, ocular, or skin symptoms. However, the pulmonary manifestation of rheumatoid arthritis include interstitial lung disease, serositis, and pulmonary rheumatoid nodules. So one should inquire about the symptoms like pleuritic chest pain, dyspnea, or dry cough. This may be a clue to respiratory involvement. Pericarditis, which is the common cardiac manifestation of rheumatoid arthritis, and it's also rheumatoid arthritis is an actually independent risk factors for coronary artery disease. Other complications which can occur because of rheumatoid arthritis is episcleritis and scleritis, and these are the recognized extra articular features. In addition to this, Zika syndrome like dry eyes and dry mouth may also occur with secondary Sjogren's syndrome. There are a number of possible mucocutaneous manifestations. These includes like rheumatoid nodules, cutaneous vasculitis, and mouth ulcers. And so one should look carefully at the skin. Recent infective symptoms where they are relevant because polyarthritis mimicking rheumatoid arthritis can result from infections like in our differential diagnosis, think about parvovirus, B19, hepatitis, and iboviruses like dengue fever and chikungunya. All these can present with the joint pain. And such infections can sometimes be associated with the positive rheumatoid factor. So establishing the patient comorbidities, this has significant implication for management of rheumatoid arthritis. So consideration should include one like chronic infections, hepatitis and latent TB, any malignancy, kidney or liver dysfunction, lung disease, cardiac failure, and also peptic ulcer disease. So genetics is thought to account for around 50 to 65% of the risk of developing rheumatoid arthritis, and multiple genetic factors have been identified. But the most well recognized is the shared epitope. It's a common 5 amino acid motif which is found on HLA-DR beta chain. So possessing HLA-DR, for example, confers a 4 to 5 fold risk of disease. So in young, if the patient is young and especially the female patient, it's important to address family planning at an early stage as this may influence choice of treatment. Like some medications like methotrexate and leflunomide, these are unsafe in pregnancy, and patients should be warned about the need for reliable contraception if prescribed these medications. So this is all about the history in patient with rheumatoid arthritis. Let's move on to the examination now. So we'll take this patient. So this patient has an antalgic gait. On inspection of the hands, there is swelling of multiple joints. There are no obvious deformities. The skin and nails are normal. On palpation, there is widespread joint tenderness and bogginess, which spares the distal interphalangeal joints. Examination of other joints is normal other than a positive tarsophalangeal squeeze. And there are no extra-articular signs, including there is no apparent rheumatoid nodules, pulmonary crackles, or splenomegaly. So very important while you're doing the examination, you're going to do the general examination and look for any extra-articular manifestations. Hand examination is very important because you want to look for any deformities which are which can appear in rheumatoid arthritis, like we're talking about swan-like deformities, ulnar deviation, boutonniere deformities. So all these deformities can happen. You must look for that one. And because this is a consultation station, so you have to do the focus examination. So important to do the cardiac examination as well as listening to the lungs for any pulmonary crackles, and also palpate the abdomen for any splenomegaly. So remember that I like to elaborate a bit about the hand examination. The hands, these are a common site where abnormal signs can be detected. There are five classic causes of a symmetrical deforming polyarthritis of the hand, and these include rheumatoid arthritis, osteoarthritis, SLE, psoriatic arthritis, and gout. Scleroderma can mimic these changes as well due to cutaneous, because of the contractures secondary to skin tightness. I already mentioned that characteristic deformities of rheumatoid arthritis are ulnar deviation and volar subluxation of the metacarpophalangeal joints, swan neck deformities, which is extended PIP and flexed DIP joints, boutonniere deformity, which is flexed PIP and extended DIP, and Z deformity of the thumb. Psoriatic arthritis, it can have a rheumatoid-like pattern. It's difficult to distinguish. A Jacquard's arthropathy can occur in SLE and also look identical to rheumatoid arthritis. However, it is differentiated by reversibility of the deformities. Importantly, fixed deformities in rheumatoid arthritis are usually a sign of irreversible joint damage. So the aim is to detect and treat the disease early before such deformities develop. So skin should be carefully inspected for features that may suggest alternative diagnosis like psoriatic rash. We're thinking about psoriatic arthritis. And if you can find Gottron's papules in dermatomyositis, and tophi because of the gout, sclerodactyly because of scleroderma, or calcinosis also can appear in scleroderma. And in addition to this, we also look for any pallor, for any Raynaud's phenomena, and muscle wasting. While doing the head examination, just look at the nails because they may provide clues pointing towards the psoriasis. If there's pitting and ridging, vasculitis, we may have splinter hemorrhages where look at the nail, or other connective tissue diseases where you have dilated nail fold capillaries. Joint palpation actually helps establish the level of the disease activity by identifying the signs of active synovitis, and these signs include joint line tenderness, bogginess, some joint effusion, and stress tenderness. Bogginess actually it refers to a doughy texture of the synovial membrane due to thickening that occurs with joint inflammation. So distal interphalangeal joint sparing is a not important negative, and it's a useful clinical clue to differentiate causes of arthritis affecting the hands. Classically, rheumatoid arthritis and SLE, they spare the distal interphalangeal joints, while psoriatic arthritis, gout, and osteoarthritis tend to involve the distal interphalangeal joints. So often, rheumatoid arthritis initially affects the small joints of the hand and feet, and then subsequently progress proximally to involve other joints. So a positive metatarsophalangeal squeeze test, it is associated with local joint inflammation, and it's a simple technique to identify synovitis in the feet. However, it is not completely sensitive or specific test. Briefly about the extra-articular manifestations, they occur in about 40% of the patient with rheumatoid arthritis, and these are much more common in patients who are seropositive. They may be a marker of disease severity, and adequate immunosuppressive therapy is associated with reduced incidence. So a thorough examination, especially including the skin, cardiac and respiratory system, and palpation for the spleen and lymph nodes should be performed. Rheumatoid nodules, well, they are associated with seropositive disease. They actually feel soft and mobile and commonly occurs on pressure points like elbows, but can occur anywhere upon or within the body, such as in the lungs. Fine crackles, well, they may be a sign of interstitial lung disease. The lungs are a relatively common location for extra-articular manifestation rheumatoid arthritis. And if there is a presence of crackles, should prompt further investigation, including a chest X-ray and likely high-resolution CT of the chest. Other investigation which we should do if we find any findings in the lungs is oxygen saturation, lung function tests, as well as looking for other potential causes, for example, infections, any occupational exposure, and ideally it should be treatment should be combined with the respiratory physician. So, if the patient has unexplained splenomegaly and neutropenia with rheumatoid arthritis, this forms the classic triad of Felty syndrome. And these manifestations occurs in severe long-standing seropositive disease. So now, because of the earlier commencement of effective treatment for rheumatoid arthritis, Felty syndrome is seen much less commonly, and it's also a diagnosis of exclusion. It is imperative to exclude other causes of splenomegaly and neutropenia, like hematological malignancies. So this is all about the examination. I think I have covered in detail that what examination should be done if you came across a patient with rheumatoid arthritis. Let's move on and talk a bit about the investigations. So considering this patient, initial blood test shows a normocytic anemia, mild thrombocytosis, normal renal function, normal liver function, other than reduced albumin. The CRP and ESR are moderately elevated. Antibody test confirms the patient is seropositive with a positive rheumatoid factor and positive anti-CCP and negative ANA. Plain X-rays are performed of the hands and feet, which shows periarticular osteopenia without joint space narrowing or erosions. So the buzzwords I have highlighted in red here. So these are all the investigations which are needed when you came across the patient with rheumatoid arthritis. So remember that normochromic normocytic anemia of chronic disease is not uncommon in rheumatoid arthritis, and it tends to correlate with the general disease activity. Similarly, an elevated platelet count may also be a non-specific feature of active inflammatory disease. White cell count may also be elevated, but sometimes may be hard to interpret in the setting of prednisolone use. Corticosteroids, particularly moderate to high dose, these actually promote the demargination of the neutrophils, and it leads to an elevation of peripheral neutrophils and white cell count. So in all investigations, renal function must be tested, because renal impairment, although it is very uncommon as an extra-articular manifestation of rheumatoid arthritis, but it is relevant in determining the appropriate treatment. Like non-steroidal anti-inflammatory drugs should be avoided in the setting of renal impairment, and drugs such as methotrexate, they can accumulate and they can cause toxicity in a patient with chronic kidney disease. Similarly, liver function tests should also be reviewed prior to treatment decision, as many drug options can cause liver function derangement, or they may be contraindicated in the setting of liver cirrhosis. Hypoalbuminemia is another non-specific marker of disease activity that may provide a clue to inadequately controlled inflammatory disease. So one should check for the albumin as well. CRP and ESR are probably the most useful blood tests in assessing the monitoring disease activity in rheumatoid arthritis, and they tend to fluctuate in saying there is some evidence their elevation may predict the relevant disease outcomes. Antibody tests actually should be interpreted with caution and always in light of the clinical picture. The presence of typical antibodies in rheumatoid arthritis, when they are neither necessary nor sufficient for making the diagnosis. About 70% of the patient with rheumatoid arthritis, they are seropositive. They are the detectable rheumatoid factor or anti-CCP antibodies. And remember that seropositivity is associated with poor outcome, including more frequent extra-articular complications and greater joint damage. So these antibodies are predominantly a diagnostic and prognostic tool, and there is usually no role for serial monitoring of antibodies over the course of the disease. So remember that positive ANA is a non-specific finding which can be found in about a third of patients, usually in the low titers with rheumatoid arthritis. Rheumatoid arthritis can also overlap with ANA-associated connective tissue disease such as SLE, Sjogren's syndrome, and scleroderma. So plain X-rays, these are mainly used to assess for disease-related damage, and so are commonly normal at baseline. X-ray may demonstrate a range of changes including juxta-articular osteopenia, periarticular soft tissue swelling, joint space narrowing, erosions, and more marked deformity later. And as you can see in the example with this and the X-ray of the hands, that there is some juxta-articular osteopenia and periarticular soft tissue swelling as well. So periarticular osteopenia is often an earlier radiographic features of inflammatory arthritis, and joint space narrowing is typically symmetrical in contrast to osteoarthritis. So if there is joint space narrowing, it will be symmetrical, present on the both sides, while in osteoarthritis may have a joint space narrowing on one side, not on the other sides. So in the X-ray erosions, these are the hallmark of radiologic finding of rheumatoid arthritis, and erosions are associated with prolonged inflammation. Erosions typically occur at the bare areas at the margins of the joints, so that's why we call it marginal erosions. And these occurs because due to synovial cytokines including TNF-alpha, interleukin-6, and RANKL, which promotes this osteoclast differentiation and invasion. So that's all about the investigations. Let's move on and talk a bit about the management of the patient with rheumatoid arthritis. So I divided the into management into two groups, short term and long term. So in the short term, we should provide the patient education and establish treatment goals. We should refer the patient to a rheumatologist, counsel about smoking cessation and taking regular exercise, commence the disease-modifying therapy early. We will prescribe short-term steroids and initiate the methotrexate with the option for additional synthetic disease-modifying anti-emetic drugs and or escalation to a biologic disease-modifying anti-rheumatic drugs or targeted synthetic DMRD in order to obtain the low disease activity. NSAIDs may be used for additional symptoms reliefs. So remember that initially that our goal is to start the disease-modifying therapy as early as possible, and usually we combine it with the prednisolone. And prednisolone is actually anti-inflammatory, so it's actually just a bridging therapy. So until the patient's symptoms are resolved, then we'll continue with the disease-modifying anti-rheumatic drugs. So treatment goals actually from a medical perspective are to reduce the inflammation. We want to prevent the damage and reduce the long-term rheumatoid arthritis associated complications. And in addition to this, we want to minimize the side effects of treatment. So usually it is a patient-centered goals such as symptom reduction, preservation of function and quality of life are also important to consider alongside. So regular exercise of moderate intensity is associated with better physical functioning as well as psychological well-being, and patients should be reassured that exercise is not harmful for their joints. Briefly about the disease-modifying anti-rheumatic drugs. They actually act within the immune system to reduce the joint inflammation and prevent joint damage. And they are usually categorized as conventional synthetic DMRDs, targeted synthetic DMRDs, and biologic DMRDs. So the aim is to start disease-modifying anti-rheumatic drug therapy early, within 12 weeks of symptom onset, prior to irreversible joint damage. Steroids, oral, intramuscular, IV, or intraarticular, can be used in the short term for more rapid disease and symptom control. We know that steroids have significant side effects. So the other disease-modifying anti-rheumatic drugs are preferred for long-term use. Methotrexate is the very important drug. In fact, it's the anchor drug of rheumatoid arthritis therapy. In the absence of contraindication, it should be prescribed first line due to its good efficacy, low cost, and generally good tolerability. So it should be prescribed with folic acid, not taken on the same day as the methotrexate to offset the side effects. Synthetic disease-modifying anti-rheumatic drugs, they work in a variety of ways to non-specifically reduce inflammation and immune activation. Several drugs fall into this category, and these includes glucocorticoids, methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. So if these synthetic DMRDs alone or in combination are unable to achieve the adequate disease control, then the treatment should be escalated to include either biologic DMRD or a targeted synthetic DMRD. All of these agents have actually comparable efficacy. Biological DMRDs, they target specific immune pathway in order to reduce inflammation in rheumatoid arthritis. They are usually delivered IV or subcutaneously, and the mechanism of action include TNF alpha inhibition. Examples include infliximab, adalimumab, and other example is etanercept. And in addition to this, anti-CD20 targeting B cells like rituximab also is in classification of biological DMRDs. Briefly about targeted synthetic DMRDs, they also has been introduced recently, and they include the JAK inhibitors. These actually is an alternative to biological DMRDs in patient with persistent disease activity despite taking the synthetic DMRD therapy. And unlike biological disease-modifying anti-rheumatic drugs, they are available in oral formulation. So remember that the treatment, it should be escalated with the aim of maintaining a patient in low disease activity or remission to prevent disease progression and maintain symptom control. NSAIDs, they have a role, and they are anti-inflammatory. They have an anti-inflammatory effect and can reduce pain and swelling. However, they do not reduce the joint damage. Hence, they are not disease-modifying agents. So patient actually should be medically reviewed at intervals determined by the clinical need. Specialist review may be every few weeks when the disease is poorly controlled and may extend to 6 to 12 monthly in stable patient. Disease activity is actually monitored using a combination of patient-reported symptoms such as pain and stiffness, examination findings like tender and swollen joint counts, and laboratory parameters such as inflammatory markers like CRP and ESR. So some side effects are common to many treatments used in rheumatoid arthritis, including the risk of infection, GI upset, and biochemical derangement. Many drugs actually require regular monitoring of bloods like full blood count, UEC, and LFTs. And Individual drugs, they may also have unique potential side effects of which the prescriber and the patient both should be aware. Another important point is rheumatoid arthritis. It is associated with accelerated atherosclerosis and is an independent risk factor for cardiovascular event. So, achievement of a low disease activity state and management of modifiable cardiovascular risk factors is therefore warranted in all patients. Osteoporosis rates are higher among those with rheumatoid arthritis due to both the disease itself as well as the use of glucocorticoids. So, patients should have other osteoporosis risk factor assessed and managed, and bone densitometry performed at intervals determined by their overall risk. And if anti-resorptive therapy is indicated, then among the management of the osteoporosis, denosumab, which is a rank ligand inhibitor, may retard the rheumatoid erosions. And in addition to this, bisphosphonates are also commonly used for glucocorticoid-induced osteoporosis. So immunosuppressive therapy, it actually predisposes the patients to develop infections. So hence all patients should be encouraged to be up to date with influenza and pneumococcal vaccine. Live vaccines, they are generally contraindicated if on immunosuppression. Joint surgery, briefly I'll talk a bit about joint surgery. It's an option in the selected patients, and most commonly joint replacement is performed as a result of secondary osteoarthritis. Joint fusion and joint realignment surgery may have a role in severe cases. So that's all about the management of rheumatoid arthritis. So when you are asked in your consultation station, there is only 5 minutes, you don't have enough time. So just focus on the buzzwords which I have highlighted in red, and just try to be systematic that when you are answering the patient about answering the examiner about the management of the patients. So start with a simple test, and then in investigation, start with a simple test, and then you go on to do the more sophisticated tests. And in the management also, remember that start with the simple things like patient education and establishing treatment goals, and then moving on to the step by step to the other managements. Thank you very much, and hopefully you have some idea about the rheumatoid arthritis, and I'll see you in my next presentation.